Hello, I am Carlos Schenck from the Minnesota Regional Sleep Disorder Center and the Hennepin County Medical Center and University of Minnesota Medical School in Minneapolis. And I want to thank the organizers for this very special REM sleep celebration event, beginning with Laborio Perino, who I know personally, but I want to extend my gratitude to everyone else, including King's College in London. Now, just so everybody knows what we're talking about here, REM sleep behavior disorder is classified as a parasomnia within the International Classification of Sleep Disorders, 3rd edition. And the definition involves undesirable behavioral, autonomic nervous system, and experiential events that occur during entry into sleep, during any stage of sleep, either non-REM or REM sleep, and during partial or full arousals from any stage of sleep. The diagnostic criteria for RBD, again in the International Classification of Sleep Disorders 3rd edition, we should call attention to the fact that RBD is the only parasomnia for which video polysomnography is required. So the diagnostic criteria involve, first of all, repeated episodes of sleep-related vocalization and/or complex motor behaviors. Second, these behaviors are documented by polysomnography to occur during REM sleep or based on clinical history of dream enactment are presumed to occur during REM sleep. Third, polysomnographic recording demonstrates REM sleep without atonia. This is the key objective finding for diagnosing RBD. And fourth, the disturbance is not better explained by another sleep disorder, mental disorder, medication, or substance use. So here's a polysomnogram showing in the top screen normal REM sleep. You see the rapid eye movements. You see complete atonia of the chin electromyogram and also of the legs and arms, complete atonia. And the EEG is the activated EEG of REM sleep, but also of wakefulness. And what distinguishes REM sleep from wakefulness is the fact that you have atonia in the muscles, despite having a highly activated EEG. Now, in the bottom panel, what you see with RBD is you have the loss of REM atonia. You have tremendous phasic motor activity and tonic motor activity of the chin and of the lower extremities as well. So this is the core diagnostic feature of RBD. You have to document REM without atonia to be able to diagnose RBD, in contrast to the top panel where you have normal REM sleep atonia. Various comments in the diagnostic classification. The observed vocalizations or behaviors often correlate with simultaneously occurring dream mentation, leading to the frequent report of, quote, acting out one's dreams. Secondly, the most current evidence-based data that are in accordance with the American Academy of Sleep Medicine 30-second epoch scoring guidelines should be utilized. And to diagnose RBD, you need a minimum of 20% loss of REM atonia, and often with patients is far more than 20%. Now, some other comments. First of all, RBD and dream enacting behaviors are not necessarily a universal finding. A comprehensive RBD literature review found that anywhere up to 35% of reported patients with RBD, especially those with neurodegenerative disorders, are not aware of dream enacting behaviors. And so dream enactment is not required to diagnose RBD in the International Classification of Sleep Disorders 3rd edition. Also, dream enacting behaviors are found with other sleep disorders. So what is the differential diagnosis of dream enactment besides RBD? First of all, non-REM sleep parasomnias in adults can present with dream enactment involving sleepwalking and sleep terrors. And a new frontier involves the obstructive sleep apnea pseudo-RBD, where patients have classic obstructive sleep apnea but present with violent dream enacting behaviors. And as I noted here, the obstructive sleep apnea RBD relationships currently a very hot topic. There's a growing literature on the relationships between OSA pseudo-RBD, and RBD in the same patient sometimes. The third differential diagnosis of dream enactment involves periodic lip movement disorder. And lastly, nocturnal seizures at times can occur with dream enactment. It's rare, but it can occur. And that's why a seizure montage is encouraged in the evaluation in the sleep lab of patients with suspected RBD. Now, our group first identified RBD in 1986. Our index patient had a beautiful description of his RBD episodes saying, quote, "I have violent moving nightmares." So we published this in the journal Sleep in 1986. So we reported on 4 men and 1 woman, 67 to 72 years of age. They had histories ranging from 4 months to 6 years, involving injuring themselves or their spouses with aggressive and injurious behaviors during sleep, often during dream enactment. The 60-year-old woman had disruptive but non-violent sleep and dream behaviors. I'm going to focus on this later on because in general, the men have more aggressive and violent sleep behaviors with their RBD compared to the women. Now, we followed up our first report in 1986 with a second report with an expanded series in the Journal of the American Medical Association, 1987. Rapid eye movement sleep behavior disorder, a treatable parasomnia affecting older adults. So RBD was first named in the second publication in 1987. We expanded our initial series of 5 patients to 10 patients. Mean age of the patients, 62 years. 9 out of the 10 were males. 5 patients had idiopathic RBD, meaning no neurological disorder was found with the evaluation at the time of RBD diagnosis. 5 patients, however, had neurologic disorders that appeared to be etiologically associated with RBD. 2 had dementia, 1 had olivopontocerebellar degeneration, 1 had subarachnoid hemorrhage, 1 had Guillain-Barré syndrome. Furthermore, 8 out of the 10 patients reported distinct dream changes. So RBD involves a dream disorder almost as much as a behavior disorder of REM sleep. Fortunately, we found that clonazepam was a very beneficial therapy in 7 patients. And I want to highlight the fact that our abnormal RBD behaviors and abnormal dreams were both controlled with the single therapy of clonazepam. So obviously the RBD behaviors and the abnormal dreams of RBD are linked very closely and both respond to the same therapeutic agent, in this case, clonazepam. So the altered dreams involve dream process change in terms of more vivid, intense, full of action dreams that are very unpleasant. Also dream content change. The dreamer is being threatened or attacked by unfamiliar people, animals, or insects. The dreamer is very rarely the primary aggressor, and there are no sexual dreams. So now I want to show you a video I put together in 1990 to educate the medical community about this newly identified sleep disorder that we named RBD. Hopefully the video will work. Our second patient showed us how he had to protect himself during sleep every night, basically, because of his RBD. He had to tie a belt around his waist. He tethered the belt with a rope to his bed frame to prevent himself from leaping out of bed. This is how dramatic and dangerous RBD behaviors can be. Now, the traditional RBD clinical profile were identified was identified in two large series. Our own series in Minneapolis, published in the Journal of Sleep Research in 1993, involving 96 patients, and then the Mayo Clinic published in Brain in the year 2000, a series of 93 patients. Our findings in the two series are virtually identical. This is a disorder in terms of the traditional profile. Older men with sleep-related injuries, sometimes extremely serious, life-threatening injuries. So older men, middle-aged and older men, dream and acting behavior, sleep-related injury. That is the traditional RBD clinical profile. However, we now know, given two recent epidemiologic studies, one in Switzerland, one in Japan, that first of all, the prevalence of RBD is 1%, which is really quite high. The worldwide prevalence of schizophrenia, for example, is also 1%. So RBD is really far more common than a lot of people realize. But I want to call attention to the Swiss study. This is a community-based study. This is not a study of clinical referrals. The investigators went out into the community and identified middle-aged and older adults with suspected RBD, and with polysomnography, they found an equal male-female ratio. So that really calls attention to referral bias. It's the men who have more aggressive and violent behaviors with their RBD that call clinical attention and have to go to the sleep center, whereas just as many women act out their dreams, but in general, women have much more mild RBD. So we need to keep that in mind. Here's a video of a woman exemplifying mild RBD behaviors. And when you see these behaviors, you realize these behaviors do not generate a clinical referral, unless that woman has a bed partner with very light sleep and might notice something. But in general, these types of behaviors, mainly in women, but sometimes in men, will not result in a clinical referral. And this is important when we get to the part of my talk, and especially with the next talk with Alex Zaranzo, that RBD is the strongest predictor of Parkinsonian disorders. And it's not the severity of RBD that predicts Parkinsonism, but the loss of REM atonia and any form of RBD. And so I'm going to talk about how we can screen for RBD in middle-aged and older patients because neuroprotective therapy is on the horizon. So you can see these are very mild behaviors that don't generate a clinical referral. And this is what I just commented on. When neuroprotection trials become available to slow down or halt the progression from idiopathic RBD to Parkinsonism, then the females of RBD who generally have milder RBD, along with males with mild RBD, need to be found in the primary care and geriatric clinics, since they also have an increased risk for Parkinsonism. Here's a single question screen, a validated screen, except it was not validated against non-REM parasomnias. I have to keep that in mind, but this is a good single question screen to then further pursue possible RBD diagnosis by polysomnography. Have you ever been told or suspected yourself that you seem, quote, to act out your dreams while asleep? For example, punching, flailing your arms in the air, making running movements, etc. So if you use this single question screen in primary clinics, geriatric clinics, you can identify patients who may have suspected RBD for further questioning, further evaluation, and perhaps polysomnography. I want to pause now for a few minutes on identifying the early scientific history of RBD. And lo and behold, it begins with James Parkinsonism in 1817. In the description of the disease that bears his name, look at case 6. Quote, his attendants observed that of late the trembling would sometimes begin in his sleep and increase until it awakened him, when he always was in a state of agitation and alarm. When exhausted nature seizures a small portion of sleep, the motion becomes so violent as not only to shake the bed hangings, but even the floor and sashes of the room. Violent dream and acting behavior. James Parkinson identified RBD without the benefit of polysomnography. Now, if we fast forward, I can now state that given the preponderance of the published data, RBD is present in about 50% of PD cases. Furthermore, isolated or idiopathic RBD is the earliest and the strongest predictor of future Parkinson's disease. Going further in the early scientific history of RBD, it spans from 1965 until 1985 in Europe, Japan, and the United States. The first experimental animal model of RBD was induced in cats by Michel Jouvet and Delorme in Lyon. And here's Michel Jouvet, National Geographic Magazine in 1987, had a story on, quote, what is this thing called sleep, end quote, and they included Michel Jouvet in front of his collection of research documents. So in the basic science world, REM sleep is called paradoxical sleep because the paradox is that despite an activated brain state, there is muscle atonia. Generally, in wakefulness with an activated brain state, we have full muscle tone and behaviors, but they call, obviously, paradoxical sleep for REM sleep because of the presence of atonia in the context of an activated brain state. So they created the experimental animal model of RBD in cats they called oneric behaviors, bilateral pontine lesions, perilocus ceruleus lesions that release a spectrum of behaviors during unequivocal REM sleep. They identified 4 categories of behaviors in REM sleep. First, unorganized head and limb movements, the minimal RBD syndrome. Second, orienting, searching behaviors. Third, attack behaviors. Fourth, locomotion, including running, the so-called complex RBD syndrome. And these findings closely match human RBD. And you can see how the cats suddenly are jumping and attacking imaginary prey. And this is from their research report. Interestingly, sexual behaviors, grooming, urinating, defecating were never found in the experimental animal model, and these negative findings also closely match human RBD. Moving on with the history of RBD, with acute RBD, investigators in the United States and Japan identified acute RBD beginning 1966 in the United States, are acute RBD emerging in the context of acute alcohol withdrawal with hallucinations, the so-called alcoholic psychosis. And then in Japan, a sleep study in patients with delirium tremens and other withdrawal delirium. So both Japanese and American investigators in the clinical context identified acute RBD with acute alcohol withdrawal. Medication-induced subclinical RBD, identified by one of the pioneers in clinical sleep medicine, Passoin from Montpellier, dissociated REM sleep with tonic muscle activity induced by tricyclic antidepressants. And then you had the Stanford group, Christian Guilleminault, evaluation of short-term and long-term treatment of the narcolepsy syndrome with clomipramine, hydrochloride, and the group at Stanford identified sleep stage 7, which is the unusual categories, but clearly they identified REM without atonia in narcoleptic patients treated with clomipramine. Now, you will have heard from Pierre Hervé Lupi in his talk that there are 2 key linked brainstem nuclei that are responsible for generating REM atonia. In the pontine tegmentum, the sublateral dorsal nucleus, and the ventral medial medullary inhibitory neurons. And in their 2 classic papers now, the first one, genetic inactivation of glutamate sublateral dorsal nucleus recapitulates REM sleep behavior disorders is in rats. And they block the descending projections that usually activate the ventral medial medulla inhibitory neurons responsible for hyperpolarizing spinal alpha motor neurons, resulting in REM atonia. And the second paper is ventral medial medulla inhibitory neuron inactivation induces REM sleep without atonia and REM sleep behavior disorder. And this is both mediated by GABA and glycine inhibitory neurons. Elegant studies that really document the 2 key linked brainstem nuclei. Oops, sorry. And then here you can see the SLD activating the medullary inhibitory neurons and then causing hyperpolarization of the spinal motor neurons. But these nuclei and their pathways are interfered with RBD and loss of REM atonia. Now, recently, the first textbook on RBD was published, and I want to call to attention in the preface that I wrote, this figure is a very important figure because it really indicates that there are multiple paths to REM without atonia and RBD. It's not just neurodegeneration. There are many different pathological processes that can result in REM atonia. And let me go around the circle here. You can have acute toxic metabolic factors, acute medication withdrawal states that I already mentioned with the early literature before 1985, brainstem tumors, stroke, neurodevelopmental factors, narcolepsy, cataplexy, antidepressant and other medications, neurodegenerative and other neurological disorders, autoimmune paraneoplastic disorders, and a very hot new area is stress syndromes that can result in REM without atonia and RBD. This is a new frontier with RBD research, and I just want to call attention to a paper by the Miranda Lim Group in Portland, Oregon, on post-traumatic stress disorder increases the odds of REM sleep behavior disorder and other parasomnias in veterans with and without comorbid traumatic brain injury. So PTSD with or without associated neurotrauma increases the risk for REM without atonia and RBD. And as I just mentioned, this is a new frontier with RBD research. Now, we identified the parasomnia overlap disorder in 1997, and basically it involves RBD and a disorder of arousal from non-REM sleep, involving sleepwalking, sleep terrors, sexsomnia, abnormal sexual behaviors during sleep, and sleep-related eating disorder. And this is classified as a variant of RBD in the International Classification of Sleep Disorders, 3rd edition. So we really are identifying a generalized motor dyscontrol across REM and non-REM sleep, and there's both idiopathic parasomnia overlap disorder and also symptomatic parasomnia overlap disorder. This is another new frontier with RBD research. Now, we need to focus not just on middle-aged and older adults of RBD, but there are a number of reported cases in the case series of early onset in adulthood under the age of 50 years. There's much greater gender parity. In general, milder RBD, greater association with narcolepsy cataplexy. Up to 60% of patients with narcolepsy type 1 have RBD. The parasomnia overlap disorder that I just mentioned, association of psychiatric disorders and antidepressant use, and perhaps also autoimmune diseases. So there's a lot of research opportunities in RBD affecting patients under the age of 50 years. Now, with medication-induced RBD, far and away number one are the antidepressants, the SSRIs, SNRIs, particularly venlafaxine and duloxetine, mirtazapine, tricyclic antidepressants, monoamine oxidase inhibitors, but not bupropion, which is a dopaminergic noradrenergic agonist. So it's safe to treat a patient with RBD who has clinical depression with bupropion. That's an important practical point, but it's interesting in a more theoretical way that that's the only antidepressant that does not induce or aggravate RBD. Also, certain beta blockers, selegiline, rivastigmine, and anticholinergics can induce RBD. Now, furthermore, RBD can affect children and adolescents, with narcolepsy type 1 being the #1 cause. Sometimes the RBD can precede narcolepsy with cataplexy by months. So if you have a child who suddenly develops RBD and nothing else, you have to be very cautious about the delayed emergence of classic narcolepsy type 1 symptoms. Also, therapy of cataplexy with SSRIs, venlafaxine, and TCAs can trigger RBD in children. The same thing with these medications in treating major depression, various neurodevelopmental disorders such as autism, ADHD, parasomnia overlap disorder also can affect children, brainstem tumors, and even juvenile Parkinson's disease. So RBD can affect patients across the entire lifespan. Acute RBD, as I already showed you, before 1985, it's mainly in the context of drug and alcohol withdrawal states, but now we know that there are additional triggers, vascular triggers involving ischemic infarcts in the brainstem, malformations in the brainstem, tumors, particularly in the brainstem, autoimmune paraneoplastic disorders, inflammatory disorders, particularly MS, also encephalitis and vasculitis, and even post-surgical with deep brain stimulation implantation. Federica Provina and Nana Tachibana wrote a really wonderful chapter in our first RBD textbook on acute REM sleep behavior disorder. And I know that Federica is one of the speakers on agrypnia excitata during this conference. Now, with chronic RBD, what are the most common associations of neurologic disorders? Far and away, neurodegenerative disorders are the most common, but as I already mentioned, up to 60% of patients of narcolepsy type 1 can RBD, various cerebral vascular disorders, but virtually all types of neurologic disorders can cause RBD, and the location of the lesion is critical in terms of affecting those two nuclei in the brainstem and their connecting pathways. Any kind of disturbance, including chemical disturbance from medications, particularly antidepressants, can result in RBD with loss of REM atonia. Focusing on narcolepsy with cataplexy and RBD, it's a distinct phenotype of RBD. Up to 60% of narcolepsy Type 1 patients have RBD, much greater gender parity, earlier age of onset, lower frequency of RBD episodes, less complex movements in REM sleep, less aggressive and less violent RBD behaviors, and classic hypocretin deficiency found with narcolepsy with cataplexy. Very important point done by elegant research by the Bologna group. There is no evidence that narcolepsy with cataplexy and RBD poses any increased risk for future neurodegeneration. It's a different phenotype for idiopathic RBD. Treatment of RBD is updated very recently in the Journal of Clinical Sleep Medicine, the American Academy of Sleep Medicine Clinical Practice Guideline. First of all, you have to maintain a safe sleeping environment to prevent potentially injurious nocturnal behaviors. That's far and away number one always. Obviously, many patients need pharmacotherapy, particularly in adults with isolated RBD or with secondary RBD due to a medical condition. The top two choices are clonazepam with up to 90% efficacy in the published literature, and also melatonin, immediate release in the United States, but I know in Europe, delayed release melatonin is used that can be highly effective as well. And then third on the list is pramipexole. In general, it is easy to treat RBD. With pharmacology. Not always, but in general, it's easy to treat. Unfortunately, it does not slow down or halt the progression to a Parkinsonian disorder, but at least you can control the injurious dream and acting behaviors. Now, what happens with RBD at the time of diagnosis? It can be associated with a neurologic disorder or be unassociated with a neurologic disorder, which is called idiopathic or more recently isolated RBD. But what happens to the idiopathic or isolated RBD patients over time? So we published in 1996 that 38% of our initial series of idiopathic RBD patients developed a Parkinsonian disorder. We extended our research of these patients and found that eventually 81% converted during a mean interval of 14.2 years from the onset of RBD. So it's really vast majority of these patients, middle-aged and older adults, developed a Parkinsonian disorder. The Barcelona group, and you'll hear the next talk of Alex Aranzo, the same data, 82% of their patients with idiopathic RBD developed neurodegeneration of the Parkinsonian type. And this is the topic of the next talk by Alex Aranzo. Now, I want to finish up by saying we now have an international RBD study group formed in 2007, legally incorporated in Marburg, Germany. We've had 15 annual international symposia, really a growing number of researchers from around the world, including 5 continents, many peer-reviewed journal articles and excellent journals. This is a photo from the last meeting we had in Copenhagen a few months before our pandemic. And I'm very happy to say that the next meeting will be held June 2024 in Oxford. Michelle Hu, who's an internationally acclaimed Parkinson's researcher and now RBD researcher, has been very gracious in declaring that she will host our next meeting in June of 2024. To finish up, a very good recent perspectives article published in the Journal of Sleep Research, and I'm also leaving for you various recent review articles for you to read. I want to call attention to the one I wrote for Sleep and Breathing. The editor actually had contacted me saying, you know, I think there's almost overemphasis on neurodegeneration and RBD because I know there's other conditions. And so that's why he asked me to write the commentary. And that's why I emphasized in that figure at the beginning of my talk that there are many different conditions that result in REM without atonia and clinic RBD besides neurodegeneration. And so that was the focus of this review article, not just neurodegeneration, but the other conditions that can result in loss of REM atonia and RBD. And also about the hot new topic of the RBD obstructive sleep apnea relationships with a literature review. I want to finish up by really saluting my longstanding friend and colleague, Mark Mahal, who died a few years ago. We worked very well together and we're great friends, and we all miss him tremendously, but he deserves full recognition in terms of the RBD story that began at our center. So thank you very much. I appreciate your attention. And this is really a momentous day. This is the actual 70th anniversary of the publication of the discovery of REM sleep by Azariski and Kleitman. Thank you very much.